The incidence of breast cancer in Black women is lower, but the mortality, the 5-year mortality, the risk of a Black woman dying from breast cancer is the highest within the first 5 years. I think the key symptoms we recommend women to be aware of, it's a breast lump, it's nipple discharge, it's change in the shape or size of the breast, and to some extent, breast pain. The survival of women with breast cancer is much better, let's say in the last 15, 20 years.
Welcome to Voices of Resilience with me, Mary Mosoeunyane, the show where we amplify Black and minority voices in UK healthcare and education.
Disparities in health persist in the UK despite all strategies to close the gaps of inequalities, with minoritized groups always facing the worst outcomes compared to their white counterparts. Why do ethnic minorities in the UK face poorer cancer outcomes? And what's the role of reconstructive surgery to access survival rates among minorities? You are listening to Voices of Resilience. I'm Mary Mosoeunyane, your host. And today we have Mr. Musa Barkeji in the room, who is our guest. Mr. Barkeji is a consultant general and oncoplastic surgeon. He specializes with breast surgeries and works within Chelsea and Westminster NHS Foundation Trust. And he's also an honorary senior lecturer at Imperial College London. And his specialism in breast cancer helps with treating patients, especially in terms of reconstruction post-cancer or during the cancer journey. Mr. Barkeji, welcome to Voices of Resilience. Before we go into the nitty-gritties of cancer and treatments, we'd like you to tell us a little bit about your journey. You are a consultant surgeon, so we just really are interested to know your journey till this far, from where you started your medical training up to now being a specialist.
Thank you for the invite. I did my basic medical training in Nigeria and then moved to UK when I secured a scholarship to come and do postgraduate training. I came in and I did my postgraduate exams and went back to Nigeria for a very short time, but the practice was so different to what I learned during my postgraduate examination. So I came back here and then pursued postgraduate specialist training in surgery.
There is evidence in research as well as stories that we hear that in various organizations, including the NHS, there is always an assumption from either colleagues or patients or whoever that someone like yourself cannot be a consultant. So can you tell us a little bit about any kind of bias you have faced, either from your colleagues or your patients, in terms of them expecting to see someone else or, So tell us a little bit about that.
I mean, I've been a doctor and a consultant for more than 20 years. It's something I face regularly. I can tell you an example. I went to one of the major London hospitals about 3 weeks ago to do a private case at weekend. And just before I got onto the stairs, a junior doctor came in and asked me, sorry, are you one of the porters? I said, no. He said, are you one of the senior porters because you look well dressed? I said, no. Not only am I a consultant surgeon, but actually I lead a whole major breast unit in UK, in London. And after that, he did say to me, oh, I'm so sorry. It looks like in part of my training, I may actually come under your, within your hospital and your training. I said, don't worry about it. He said, I'm sorry that I made that assumption. So, yeah, it's something after all these years, one still face. When I came in here, to go into specialist training, you have to go into an interview, a national interview, and all doctors, either UK or non-UK trained, have to go through that to be selected. And when I got into the training, it wasn't a straightforward way, in the sense that at a certain stage of my training, 3 of us were taken off the training because we did not have a UK citizenship at that time. And then I had to go into non-training post for a very short time to secure my UK citizenship, and immediately after that, I got back into surgical training to complete. I did the last few years of my training in Cambridge in Addenbrooke's Hospital to become a specialist in breast cancer treatment.
There is evidence record that, over the years, because of advancement in treatments in all cancers, not just breast cancer, patients' outcomes are much better. However, in regardless of the fact that in general outcomes are better, people are living a bit longer. I was listening to the news actually yesterday, probably it was BBC. I know they were concentrating mostly in Wales, but generally that the chances of survival with cancer now is about 70%, which really is great. So with the survival rate being great, and we are aware that obviously there's always research going into cancer and all of that, but the evidence is that regardless of all this, the minorities, maybe particularly talking about Black women, still face the worst outcomes with cancer. So, Mr. Barkeji, I'm interested to understand why this is a consistent, continuing picture. Does it have anything to do with the biology of cancers in Black people, or does it have anything to do with culture? What is it really that makes all of this poor outcomes in prognosis?
I think there is now very clear evidence that generally Black women do worse than all other races. The incidence of breast cancer in Black women is lower, but the mortality, the 5-year mortality, the risk of a Black woman dying from breast cancer is the highest within the first 5 years. There are a number of factors. There are society, there are biological factors that contribute to that. There's a lot of data coming from America. 12% or 12.7% of the US population are Afro-Caribbean. But the incidence of cancer and the death is much higher if you compare it to that. One of the factors is there are more Black women diagnosed with breast cancer at a much younger age. Black women also tend to have a particular type of cancer, breast cancer, that is called triple negative. Breast cancer cells can have different hormonal factors. I think we are all familiar with estrogen and progesterone, which are part of the oral contraceptive pills or hormonal treatment that women take. So breast cancer cells can express these factors. There's a third factor which we call HER2. So Black women tend to have more what we call the most aggressive type of breast cancer that is called triple negative. If you look at the wider population, 21% of Black women will have triple negative breast cancer. So we're talking of 1 in 5 women, one in 5 Black women will have triple negative cancer. While in the Caucasian population, it's 1 in 10. We know that the risk of dying from triple negative breast cancer is the highest. Black women also tend to generally present at a later stage. There is very low uptake of breast screening in Black women. The stage of cancer at presentation is much higher, which imply that by the time a Black woman is diagnosed with breast cancer, the lump is bigger, but also more likely the cancer has spread to the lymph node or to the rest of the body. The treatment becomes much more complex. And then you're talking of chemotherapy, radiotherapy, and major surgery. So in general, the outcome is very clear that Black women do a lot worse. As I said, it's a mixture of many factors. If you look at the data in America where women depend on insurance, that's much more stuck because fewer Black women have medical insurance. In UK, the NHS provides equity in care, or at least that's what we seems to see. But still, Black women tend to present to the hospital at a much, much later stage with a much advanced cancer.
Okay, so in other words, you are saying that, yes, definitely, like you're saying, there are many factors that contribute to this, but also I can see you're highlighting how they tend to be diagnosed at a late stage where the cancer has already advanced. And so I just want, if we can just stay with that a little bit. So what is it that makes these Black women to come late for diagnosis, if that's how I may put it? Yeah. What is it that is preventing them to access, health or assessments, or maybe things like mammograms, all of that?
So a number of factors. So the first thing I said is that Black women tend to be diagnosed with breast cancer at a much younger age, less than 50. The national breast screening program starts from 50 in the United Kingdom. So you find that a large number of Black women will have breast cancer between the age of 30 and 40 or up to 50 before the time of the mammogram. The uptake of screening mammogram within the Black population is the lowest of all the different. When you look at other specific groups of Black women, that's even much lower. If you look at possibly the Somali and the North African, it's quite a low uptake of screening. Is it due to language? Is it due to just availability? I think there are lots of factors that contribute to that.
I'm thinking about some of the conversations that happen in communities, where, even just, kind of day-to-day conversations, even within education spaces, whereby sometimes there's almost a myth that Black women fear being told they've got cancer. So they shy away from actually, if they were called, for instance, by their GP to come for a mammogram, some of them may actually not come because they would rather stay not knowing than actually knowing. So can this confirm some of the experiences you have had when you talk to women about this?
Yes, I think there is little understanding or expectations that breast cancer can occur in the Afro-Caribbean population. I don't think this is something that is well spoken about or talked about in the communities for women to be enlightened to say that you need to check your breast, you need to be aware of the risk. I think you see that a lot more in the Caucasian community where breast cancer, with long historic factors, people know about their family history, their relatives. We don't talk much about breast cancer in the Afro-Caribbean population. And therefore, by the time women are found to have breast cancer, as I said, it's usually at a much advanced stage.
Yeah. So I just wonder whether maybe there's one key message that you can tell us that shaped your understanding of cancer, especially within diverse communities. In a sense, I think you have mentioned that they tend not to talk about these things. Is there anything else maybe that you can tell us?
So there's been huge advancement in the management of breast cancer generally. The survival of women with breast cancer is much better compared, let's say, in the last 15, 20 years compared to before that time. A lot of the breast cancer trials where you look at the research, the chemo agent, the effect, what dose to give, how to monitor the patient, the uptake or the attendance to breast cancer trial and research within different community is very different. While you see a lot of Caucasians attending breast trial, very few Afro-Caribbean women attend any trial or join into trial. So therefore, the medicine, the way it's given, the side effects, the other issues that are related to the different treatment of breast cancer, chemo, radiotherapy, it's really not been examined very well in the Afro-Caribbean population. I think that's one of the key, I wouldn't say it's failing, but I think there is an opportunity for enlightenment in that population.
You have just really made it a point that the listeners are hearing you out. You said be breast aware. And I just wonder at this point whether when we look at symptoms themselves, how do they present? What are the symptoms? And do they present differently in different ethnic groups?
So not necessarily hugely different. I think the key symptoms we recommend women to be aware of, it's a breast lump, it's nipple discharge, it's change in the shape or size of the breast, and to some extent breast pain. I think generally Afro-Caribbean women tend to be slightly heavy-breasted. If a woman develops a lump or a cancer right at the back of the breast, it may take months for her to notice a lump. And that's why that being aware and getting to know once a month to examine yourself, to get to know how the breasts feel, how they look. So as I said, one of the 80% of women with breast cancer, the women pick the symptoms. 20% are picked from screening. So it's really important of that awareness, because that's when majority of the cancers are picked. So when I see women in my clinic, one of the things I say to them, 5-7 days after your period, when you have a shower, just before you get dressed and go out, stand for 2 minutes in front of the mirror, look at the shape, size of the breast. Are they in the same position? Is one looking this way, the nipple? That simple things. And if that persists, I think it's worthwhile for you to go to your GP. And a lot of GPs now understand that if there's any symptoms in the breast, the GPs will send the patient for a scan. Now, one thing the NHS is very good at is actually what we call the 2-week wait or 2-week referral. If a woman is referred to the breast, a lot of GPs will tick a box. It says 2-week, which means suspected cancer. What that really means is that the NHS expect every patient referred to the GP with a suspected cancer, the patient to be seen within 2 weeks. I think that's really good. As we said, the biggest issue is that women do not present early. So yes, if women get to know how to examine themselves, looking for lumps, distortion, changes on the skin itself, or palpable lump under their arm, I think not to really ignore these signs, because breast cancer is common. 1 in 9 women do get breast cancer in their lifetime. But also, if you pick the cancer early, we're talking of few months, it makes all the difference. It makes the difference between a lumpectomy and a mastectomy, where a woman loses the whole of the breast. So I think it's all to do with breast awareness.
What does oncoplastic surgery offer patients when compared to the traditional removal that oncoplastic does, in comparison?
I think that's been one of the biggest advancements in surgical techniques for managing breast cancer. If you look at either pictures or women who have had breast cancer treatment 20 years ago, a higher number of women will just have a mastectomy. Or you make an incision and take the cancer and the breast is left completely disfigured. Now, I think that's contributed in women being afraid to really go for this treatment. The word oncoplastic, it's a combination of treating the cancer and also plastic procedures to optimize the cosmetic outcome of the breast. So what we do these days, I think the population or your listeners will be familiar with women going to have breast uplifts. And that's one of the key techniques we use now. Generally, Black women tend to have a slightly larger breast size. Where they have cancer, we use a technique where we not only take the cancer out, but actually we reshape the breast completely in a much more cosmetic way. And often a woman will come with a small cancer on one side, but when you treat the cancer, let's say on the right side, you lift that breast. At the same time, you offer her the possibility of doing it on the other side. And I think that seems to be there's a high uptake, and that's almost become now a standard of care. This is something that we offer a woman. You maintain the patient's body image. You maintain their sexuality. Publicly, when the women are out in the community, they really don't look any different to a much more younger looking breast. So that's really, in a short form, that's what oncoplastic surgery. It's combining cancer and plastic procedure to optimize the outcome of the breast.
And this is in the NHS as well, not just privately.
Absolutely. So I think this is, I would say, for almost all my patients that are having lumpectomy, or what we used to call lumpectomy, I will not just go and just take the lump and leave the breast disfigured. It's almost a standard now that we'll look at options where we kind of reshape the whole of the breast to maintain that nice contour. Either by moving the tissue around or taking tissue from somewhere, or sometimes we even offer women, we do liposuction from the lower abdomen, from the thigh, use that fat tissue to kind of reshape the whole of the breast so that the breast is looking nicer. And in some women, they will tell you, actually, it looks better, or it looks just before I had my children. Thank you, doctor.
Yeah, I think I need this kind of surgery myself. Thank you, Mr. Barkeji. You mentioned clearly that there are different types of cancers, and that Black women tend to present with what we call triple negative tumors.
Yes.
And also you mentioned that when we look at clinical trials, the uptake is much low in the Black communities.
Yes.
So probably my question then is if there is a lower uptake of clinical trials and Black women are presenting with this kind of tumors, in terms of then treatment and management, what guides your treatment of these women if in the clinical trials it's mostly Caucasian or white women who are showing up? How is the treatment then more specific for Black patients, if I can put it that way?
Yeah. So I mean, it's all evidence based, and I think the way we treat breast cancer, particularly for Afro-Caribbean women, when they present to us with, as I said, larger cancers, more cancer that may have spread. If the cancer has spread from the breast or to other part of the body, surgery is really not a good option at that stage, and you're looking at possibly just chemotherapy long term. There is not a huge difference in the way we use chemo agent between the different races. As I said, most of the trials are based on Caucasian women. So we do not do a different titration or change the medication. Obviously, the weight of the patient and other things may determine, and the biology of the cancer may determine the way we give the medication. But we don't do anything that is specific. And I think that may be something that actually the medical society is missing, because we know biologically the cancers can be very different.
That's really interesting, something to probably delve into. So, like we are saying about outcomes, especially in terms of specific cancers that affects women, and clearly you have said about the clinical trials being lower in Black women. So my question really is around, you have mentioned some factors that can prevent maybe Black women accessing healthcare in a sense. And I just wonder whether in your experience as well, whether by research or by observing patients, when it comes to the actual treatment, like you're saying that when you are treating patients, you don't particularly have a different treatment, because cancer is cancer at the end of the day.
Sure.
So in terms of the treatment uptake itself, in comparison, because we learned that chemotherapy, unfortunately, as much as it can kill the bad cells, it also kills the good ones.
Yes.
So, and sometimes patients may actually die of secondary problems like infections, not so much the cancer itself. So what is then the impact of chemotherapy if you were to compare between Caucasian and the minoritized women, whether it's Asian as well as Black women?
I think generally from my own experience, Caucasian are more likely to accept chemotherapy. I think the idea of having chemotherapy in the Afro-Caribbean culture, I think it's lack of familiarity. I know of a number of young Afro-Caribbean patients that I've seen and diagnosed with breast cancer that need to have chemotherapy and have declined having the treatment because of difficult to put a finger sometimes, I think there's a suspicion that whether they are being told the truth or accepting that this is what they have. The number of patients that I know that have declined treatment and really have had a very bad outcome within a very short time, it's quite high. I think in the Afro-Caribbean culture also, because we know one of the major side effects of chemo is hair loss, for example. I think that's something that women struggle to accept, particularly in the Afro-Caribbean culture.
You mentioned earlier on about some cultural issues, things like probably stigma, and now you're talking about hair as well, because obviously hair is quite important, and these are some of the things that may be obstacles in people accepting chemotherapy per se. We also probably, from evidence of literature, that minorities, maybe especially Black people or Black women, tend to have a mistrust in the healthcare system. I think you kind of mentioned that. So there is a level of mistrust because they believe that some of the treatments are there to get Black people, to clear them off the earth. Yeah, so some of this may be myths, but these are some of the narratives that we hear. So what is your take with this, Mr. Barkeji, as a scientist?
I think that's a difficult one in the sense that I think it's a long established cultural issues where I think there's, as you said, there's a mistrust of the healthcare system. I think we know it's the same thing that happened with COVID. At the start, there's a high death rate in the Afro-Caribbean community, but here and in the US, some of the very, I think historically, there are a number of trials that were done on Afro-Caribbean patients that is well known in the community that people don't trust that. I think the most famous is the syphilis trial that was done in US where black men in particular had a very bad outcome in that. And yes, you say this is around the time of slavery, but black women were literally used as guinea pig for this trial. So I think that has gone along in the mind of black people. I think also when Afro-Caribbean women go to the hospital, they really don't see people that look like them, people that speak like them, that talk to them at the same level, and there's always a perception of different grade. So I think there are a number of factors that really make it very difficult for people to accept these treatments.
So in a sense, we can say that the mistrust is not far-fetched. It could be something that is embedded within the structures of organizations, which probably has persisted for quite a long time. You know, like you mentioned clearly that some of these things came with slavery, but they haven't left the system as yet. And so these are some of the challenges that we are still facing. And I'm sure that, our listeners listening, they've got their own stories to tell. They've got their own perceptions. And I know that obviously as a scientist, you would like people to come on board and get the treatment that they deserve. So it's about creating some awareness and speaking out for people to really come forward. You are listening to Voices of Resilience, and this is a platform where we amplify the voices of the minoritized by inviting specialists in specific areas to come and share their expertise, their wisdom, as well as their research, especially actually speaking to people out there in the language that they can understand. When I say language, I mean at the level that they can actually understand. So we have had the story, you have shared some of the research as well. And for our listeners, obviously, we want to bring some of these challenges in the forefront. And also, we don't want to leave people just hanging with challenges. We also want to see what can be done. So how can we resolve some of these issues? What are some of the solutions that we may be looking for, as it were? So, Mr. Barkeji, what changes in outreach, screening or treatment pathways offer the most promise to close the survival gap?
Okay, so let's start with outreach. I think it's obviously what you're doing now, kind of informing the Afro-Caribbean population, the ethnic minorities, about breast cancer awareness, black women to understand that actually breast cancer does occur within our community, being aware to what we call breast aware, where women get to know feel the look of the breast, women to know about that it's important to examine your breast. We encourage women to do it once a month. Usually we say for premenopausal women, 5 to 7 days after you start your period, your hormones level are lowest, the breasts generally tend to have a much more consistent feel. So it's really more about education, about awareness, about to make it something that women feel free to talk about and ask questions. Young ladies talking to their moms when you have a family gathering about breast awareness and the fact that actually breast cancer is probably one of the leading cause of death in young black women. So I think that's more about education. You've got organizations where you have a group of women go to, in the religious setting, in churches, in mosque, in other I would say, cultural event where people gather, where this can be something to discuss, but also more people like you kind of bringing up this kind of topic. So that's the thing to do about awareness. I think the second issue is about screening, as you mentioned. In US, for example, breast screening will start at a much earlier age, probably a decade earlier. In UK, breast screening starts from the age of 50. And we've just mentioned that actually a lot of Black women will have breast cancer at a much younger age with worse outcome. The question is there any appetite in the NHS for lower age screening, being that the Afro-Caribbean population are a minority in this society? I think health advocates, publicity about it, campaigns by kind of a well-known Black groups to say that this is something that needs to be discussed more openly to see can there be. I think encouragement also, as we mentioned, about clinical studies, clinical trials in so many, not only in terms of breast cancer. I think that is a well-known that we, the Afro-Caribbean population, rarely or hardly attends for clinical trial. It's the same thing with blood transfusion. It's the same thing with organ donation. Yeah, you find Black people that needs blood or other things. We just don't. It's not something we tend to do. Kidney transplant and whatever. The number of Afro-Caribbean that have donor card in their pocket is very low. So I think it's more to do with education, but also try to engage people into that role.
Yeah. No, thank you so much. And you mentioned something really important about communities. For instance, community means if in the church, isn't it? Because
Yes.
we do know that a huge population of Afro-Caribbean people, if not all, they actually go to church.
Very
And we
religious.
do know that they tend to trust their religious leaders even more than a doctor sitting in a specialist area, isn't it? So really important that you are mentioning that. And I'm sure that, church leaders also listening to this, they are already being empowered that, it's really important for you to spread awareness about breast cancer, to normalize these conversations. Like you mentioned that sometimes in Black communities, some of these conversations are not normalized. I don't know, it carries some kind of stigma. People want to keep things secret. And yet at the end, then they end up really with detrimental effects because then they don't seek help early. They get, by the time they are being diagnosed, the cancer has already metastasized. And talking of which, Mr. Barkeji, for you as a doctor, every time you had to tell a woman, especially a younger woman, that you've got cancer, what kind of emotions go through your mind when this happens, and how have you managed to navigate all of that? If I'm sure that sometimes when you are running a clinic every day, you have to tell someone some bad news. How do you self-care?
I think that's probably one of the difficult part of what we do, because each and every time you give that news, it's a point of reflection that this is actually one of the major life-changing event for the patient, to be told that one has cancer at whatever age. And even 90-year-old, I think I've spoken to a 90-year-old and operated on recently. Even at that age, telling somebody that this is cancer, you can see the sadness that flows through the body. But in the population we are talking about, it tends to be actually in their most productive years when it happens in your age of 30 and 40. But it's not only having the cancer, it's all the whole family, the impact on the family, on the children, on attending chemotherapy. So the whole family dynamics changes because of that single diagnosis. But also then you start looking at 5-year mortality, 10-year, what is the likelihood of this patient surviving for 5 or 10 years. So I think that's a very difficult part of that. But I think where the news is delivered sensitively to the patient, I think there's also some satisfaction that you've been there to support the patient and help the patient. But also, particularly if one is able to deliver that news in a very easy to understand. Difficult, but I think also something that, it's part of what I do, and something I take very seriously.
We have mentioned some of the outreach programs to reach the community, such as, churches, all of that. In your work at the moment, Mr. Barkeji, are there any community-led screening efforts that are tailored for the journey of this patient, surgical planning and how this has improved outcomes? So I know that obviously you work within NHS, and I don't know whether in your organization, in your team, are there some outlets for that are attached to community based kind of outreach?
I think majority of hospitals where you have cancer services will have some community. Often they are charity. We have one in my hospital. We have a charity that is funded where women will go in. They have a lot of classes where the patients, I hear the breast care nurses using that the patients go to be pampered. They have a massage. They have so many kind of a treatment. A lot of women find it very helpful. I think the NHS is struggling in terms of capacity and finance, but having a counselor in the service, somebody that can speak to the patient, but also hold the patient's hand along that journey. I think these are the kind of things that really do help. But having, as we said, culturally sensitive discussion where patients can relate and speak to an individual in the language that they understand, I think that really does make a big difference.
So how can clinicians, advocates, or listeners support more equitable access to reconstructive surgery as part of cancer recovery? Because as you can imagine, whoever our listeners are, some of them will actually be clinicians, some of them will be advocates, some of them will be working in the charities that you're talking about.
I think it's getting engaged. I think one thing that is good with UK is people can either write to their MPs, to the local hospital. As I said, this kind of podcast that you have here, different organizations where you can kind of advocate and say, can we give priority to try and improve the healthcare? I think in the last year or so, I think it's well known that Black women who go into labor, obstetric outcome for Black women is worse than the Caucasian in the United Kingdom. I think that publicity, the fact that this is something that has been discussed in the parliament, is being chaired by some prominent Black women, but also some other MP to say, how can we improve the outcome and the healthcare of these minority groups? I think that's kind of been very good to know. And I know a lot of hospitals now are specifically looking at, because this is something they are looking at. I think that transparency in the discussion, but also sharing the data of ethnic outcome in different groups, I think that's been very useful.
Mr. Barkeji.
Yes.
Thank you so much for sharing with us your expertise and your clear dedication to your patients within NHS as well as the private sector. Could you share where our listeners can learn more about your surgical work or research, please?
I work in Chelsea and Westminster Hospital, so the information is available. The NHS is there. I work in a private hospital, a number of private hospitals in London. I think that will be the source of this information.
Lovely, thank you. And just before we close, for the sake of our listeners, can you tell our listeners as a takeaway message for today's conversation, please?
I think the first thing to say is that actually breast cancer is real. It's there. It does affect every community. But in particular, I think there needs to be more awareness of the poor outcome in terms of women with breast cancer in the Afro-Caribbean population. That it does occur at a much younger age, in the 20s and 30s. women tend to do very badly. But also, I think my key message will be that where women present early and the diagnosis is made at a much earlier stage, there are more options in treatment. Survival is much better, but also the magnitude of the treatment can be less. It's not every patient that needs to have chemotherapy. It's not every patient that needs to have a whole mastectomy. If women present at an earlier stage, then outcome is much better. So if there's anything I want to say is that women should be just breast aware, but also if there's any symptoms that persist beyond 1 or 2 months, please go to your GP, make sure that this is seen, and you are referred to a specialist to have the right investigations.
Yeah. Thank you very much. Really important message today. We are really grateful that you came to join us at Voices of Resilience. Thank you, Mr. Barkeji.
Thank you for the invite.
Thank you so much for watching. If you found this episode interesting, please like, subscribe, and hit the bell so you don't miss the next one. Next week, I'll be joined by Dr. Wayne Mitchell to unpack the Black PhD experience, the barriers, the breakthroughs, and the resilience it takes to thrive in academia. Till then, take care and keep listening to the Voices of Resilience.